Hello everyone. Today we shall have a session on human papillomavirus and the dermatological conditions that you usually see because of this virus. So as you can see in this picture, we start with this picture on where the cursor is. Now this picture tries to show you someone who has various verrucous papules and plaques on the lower limbs, and in this picture someone has extensive warts, as you can also see as well on this foot. So when you see such a presentation, you may keep wondering what is going on, and it is the role of this lecture to enlighten us on the cause of these verrucous plaques on the legs. So the human papillomavirus is one of the commonest viruses that you have affecting people in this world. And it is so common that you may find that almost everyone has encountered it in one way or the other. Maybe we can find some actually infected, maybe without manifesting with symptoms, and then others can be infected with symptoms. So the human papillomavirus is a double-stranded DNA virus, and this virus has about 800 base pairs. Usually these viruses in this category are characterized by slow growing. They are able to replicate in the nucleus, and as well, this virus can show latency, so they can be in your body upon infection until when you die. So they belong to a family called the Papillomavirus, and in this family, we've known about 200 different genotypes, and these genotypes are generated depending on the similarity of the viruses in their genome. And what we know characteristically is that this group is very resistant to heat, drying solvents, and as well as freezing. So in case you have like medical equipment that have been used to work on a patient with these viruses, even after them drying out and maybe you leave them there maybe under the sun, those equipments are still infectious. Even a chair where a patient has sat, if they have maybe genital warts and they sit on a chair, they leave there the virus, and this can be infectious to the next patient. So when you're managing people with this virus, you need to be a little bit more aggressive because this virus can affect and can stay on fomites for a very, very long time. So we look at the prevalence of this virus, it affecting about 30% of school-going children, and it is as high as 70% in men who have sex with men. And when they infect you, their cellular target are the basal keratinocytes that we find at the base of the epidermis, and they can be transferred from one person to another through various ways, including vertical transmission, that is from mother to child, sexual transmission, and then also contact. The humans are the only known host and reservoirs for these viruses, and in their genome, as you know, is when you say genome of a virus, that is the DNA. So in their genome, they have characteristic genes that we usually group into 8 early genes and then 2 late genes. So these genes encode for different proteins that facilitate the virus when it has entered your body, and the L gene encodes for the L protein, which is the major capsid protein of the virus, and this one is usually rearranged into what we call viral-like particles, and this is very key because it forms part of the vaccine that is currently available. They generate a vaccine basing on the viral-like particles that are generated from this L1 protein. Then L2 gene encodes for the minor capsid protein. This helps to expose the keratinocyte binding site of L1 in case when the virus is binding to the basal keratinocytes. And what you have to note is that this virus, upon infection, it is able actually to downregulate the function of the Langerhans cells within the epidermis through the phosphoinositidine 3 kinase pathway. And when you do this, that means that you are not able to do what we call antigen presenting. So the virus infects you without your body actually responding. And then the other protein, the E6 and E7, these ones are very key because they bind to the P53 and the retinoblastoma gene. And when this happens, when you block this, the P53, you know that one, that means that you have now acquired immortality. And when you block these genes, these viruses are able to actually promote cell growth, but at the same time, they prevent these cells from triggering apoptosis. because we all know that in case a cell is infected by a virus, most of the times your body automatically activates the immune system so that these cells that are infected can be eliminated by the cytotoxic T cells. But now in this case, because of this potence from the virus is able to evade the immune system and proliferate without your immune system being able to fight it out. Then you have these other early proteins, the E6, 5, and 7. They also reduce the local production of immune reactants, especially through the toll-like receptor 9 and then the interleukin 8. We know the interleukin 8 is a chemoattractant for neutrophils as well, and it also triggers the immune response. So because of these properties of these viruses, they're able to cause latent infections and lifelong infections as well. So we classify them depending on the clinical manifestation, and then this one gives rise to what we call variants, or the different types of how the virus presents like. So the first group we call the Verruca vulgaris, or the common ones. This is usually contributes to about 71% of all infections from the human papillomavirus, and it affects age groups starting from around 5 to 20 years, and only 35% after 35 years of age. So most of this Verruca vulgaris is common in the young population, and it is caused by the types 1, 2, 4, 27, 57, 29, as well as 63. So the risk factor for developing the common ones include people who usually love playing in water, swimming, because we said that this virus can be on fomites, and then public exposure, people who handle meat, and people who move on foot, if you move barefooted. And then the common locations include the hands, fingers, palms, and soles, but they can be anywhere in the body. So in case a child has Verruca vulgaris, how would be the natural history of this virus or of these warts? So first of all, for some people, as their immune system develops, the immune system is able to wake up and then fight the virus, and the clearance rate depends on the age. So 25% of these warts usually resolve in 2 months, 35% by 3 months, 50% at 1 year, and then up to 78% by 2 years, and up to 90% by 5 years. So in this case, if a child has these warts, you can do what you call benign neglect. You don't actually treat, you cancel the mother and tell them that one day the virus will go away by itself. But the problem is once they stay there, they can, and the child keeps scratching, you can get what we call auto inoculation. For example, if the first wart was here, as you can see on this picture, as the child scratches, they develop more warts and more warts. So it may be better suited actually to do something about these warts before they spread. If it is a solitary lesion and the mother is comfortable for you to remove it, you can actually remove it, and then the child will be better. Then you have a variant we call pigmented warts. This is very commonly reported in Japan, and it can occur in hands and feet. Most likely, the hyperpigmentation has been attributed to to proliferation of the melanocytes that are located within this basal layer of where the wart has affected, and it has been associated with the human papillomavirus type 4, 65, and as well as 60. So usually, the theory is that because of blockage of transfer of melanin from the melanocytes to the keratinocytes, it causes accumulation of this melanin within the basal cells. Then you end up with what you call the pigmented warts. Then you have what we call the flat warts, also called Verruca plana. Plana just means flat, and or plain, it means flat. And in this case, they're very common in children, especially on the face, and they are due to HPV virus 3, 10, 28, and 41, and they're common in children. Usually, they like the sun-exposed areas, and in most cases, they'll show what we call cognialization, whereby if you see scratch, you get what's developing along the line of the scratch, as you can see on the face of this young child, where we have these flat topped warts that are on the sun-exposed areas. We also have what we call the plantar warts. Plantar is the sole, so also called Verruca plantaris. In this case, they contribute to up to 34% of all the cutaneous warts, plantar warts. So they're due to HPV 1, 2, 27, and 57. And they usually love areas where you have a little bit of pressure. They can occur singly or in very many at once, and they have different variants depending on how the surface is looking like. So we can have the rigged warts, which are usually you get a wart but with persistent demographics, Usually this is due to HPV-16, and then you can also have the mycelia type, whereby you have the asymptomatic surface and a deep plaque. This is usually confused with the parenchyma, and it's due to HPV-1. So in this case, this is the WART that you see. So in cases where you see a WART or any verrucous lesion on the pitch, you can have actually to distinguish between what a WART is. May have to distinguish what callus is, and may have also to distinguish what a cone is. So in this case, you do what you call paring. Paring, you just get a surgical blade, you cut on the surface of the wart. So if the surface of the wart, after cutting, you realize that you get very pinpoint bleeding or tiny dots, black dots, what we call thrombotic blood vessels, then that becomes a wart. In case you do paring and you don't see that, that becomes a cone. Then for colors, usually colors, there's a preservation of the dermoglyphics. So that means that you'll have a thick plaque, but the skin lines will be intact. Actually, they will even be accentuated. So in that case, you're able to distinguish clinically between a wart callus and a cone. Then the next one is what we call the genital warts, or the external genital warts. Usually, this is also one of the commonest sexually transmitted disease, and it is up to 50% in sexually active young adults. You may find them having these warts. So it's also related to malignancy, because you know that the human papillomavirus, some of the groups, high risk viruses, they can cause cancer. So every time you see genital warts, you have to screen the patient for HIV, syphilis, all those sexually transmitted conditions, as well as you have to screen them for cancer. If they are female, you have to do a pap smear to make sure they don't have HPV infection around the cervix. So the risk factor usually of developing cancer depends on the type of the infection, which virus type has infected you. Is it high risk, intermediate, or low risk? Then if someone is smoking, and also the site where the virus has gone. So sometimes, depending if the infection is within the rapidly growing cells of the cervix at that border, then you end up getting a risk of developing cancer. And then the circumcision status, if someone is circumcised, usually we know that you remove the prepuce or the foreskin, so the remaining skin becomes tough, and the turnover becomes less as compared to someone who's not circumcised. And we know that cancer loves areas where the cells are rapidly dividing. That gives ground for committing errors. Then the immune status, when you're immune suppressed, your cancer screening in the body reduces. That means that there's a high risk of developing cancer. So the genital warts will look like something like this. These verrucous plaques, they can be single or multiple, and sometimes very, very extensive. So in the clinical manifestation, if you are to see the warts and what usually they present like and the different variants of the warts, you can take a look at this table. So we have the common warts, we've talked about them, and we know that we have looked at the different genotypes that cause them, the HPV-1, 2, 27, and 57. And then we can have the flat warts being caused by major 3 and 10. Then you have the butcher's warts, mainly caused by 7. And then you can also have the decreased squamous cell carcinoma or Bowen's disease caused by 16. You know, 16 and 18 are the high risk, and they love causing cancer. Then we have EDV, epidermodysplasia varioliformis. This one is usually caused by 3, 5, and 3, 5, and 8. And then you can have the squamous cell carcinoma, usually caused also by 5 and 8. So this table tries to summarize the different manifestations and then the genotypes that are usually implicated. Then X disease, we shall look at X disease, which is usually to HPV 13 and 32. So then you go to condyloma acuminata. So condyloma acuminata just means giant lobulated papules, which are usually 2 to 5 millimeters in diameter, but can even be bigger. So usually this is caused by intermediate risk, which is HPV-6 and 11. And they will give you this called flower masses, which is usually in the genital area. And usually it is very moist, especially in the occluded areas in between the gluteal folds. And this is how it will look like. Very big, giant, and verrucous. So This table here on the side tries to show us the high risk and the low risk viruses. For the low risk, we have 6, 11, 42, 43, 44, and they also cause genital warts. And then high risk, we have the common ones being 16 and 18, and usually these ones are the troubles, but others include 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, and then 68. So these genotypes have been implicated in cervical cancer. So we also have what you call the Bowenioid pustulosis, and in this case, you have a precancerous lesion that is due to a change in the cellular, causing cellular atypia in patients who are infected by HPV-16 and 18. And in most cases, it usually progresses to squamous cell carcinoma. As you can see in this picture, this is the arrangement that we have. So if this patient is not managed in the due time, they end up with squamous cell carcinoma of the genitalia. Then we have also the giant condyloma acuminata, also called the Basque-Lowenstein tumor. So this is just size, but it has been associated with HPV-16. So in this case, you have a very, very big giant tumor, which can even go to kilograms in some patients. So it can be very, very big, and it has been associated with HPV-6, unless you can remember that. And in some cases, in some case reports, it has been shown to metastasize to different areas in the lymph nodes, in the gluteal area, and also in the inguinal area. So the treatment is you have to do a complete excision, but then you have also to do a lymph node biopsy to make sure that it has not metastasized to the nearby lymph nodes. Then you have what we call HEX disease. Now, HEX disease is due to HPV-13 and 32, and usually presents in the oral mucosa. And in this case, someone presents with small white to pinkish papules, as you can see in this picture. And it's also called epithelial hyperplasia. It's commonly seen in Asian populations, and also seen in South Africa among the Khoisan. Up to 35% of them have this virus. It is more endemic in that area. But even at our clinic, we're able to see this child that you see here with this white to pink papules. Some of them coalesce into form plaques on the mucosa of the lower lip. So when you see this disease, this is also caused by the human papilloma virus, called HEX disease as well. So we also know HPV to cause recurrent respiratory papillomatosis, and this will be an ENT issue, but it is associated with HPV-6 and 6 and 11. And in this case, it is common in patients who have different sexual practices, including cunnilingus and the rest. So you see that someone maybe has an infection of HPV-6 and 11 down. Then when you do that, then you can make this virus to go into your respiratory tract to cause this recurrent papillomatosis. And in this case, someone present with noisy breathing, respiratory obstruction, and it has been shown to have a bimodal distribution, whereby the first peak occurs in early about 5 years of age, then the other occurs around 15 years of age. And it was also thought that it is transferred from mother to child during that period of childbirth. And if you see it in an adult, then you question their sexual practices. In some cases, it can progress to a carcinoma in 40% of the children. And during the treatment, you have to excise them surgically, and then also usually add on acidofovir. And there's also a role of HPV vaccination in trying to control recurrency and to improve the outcome. Then we have this very common condition in patients living with HIV, epidermodysplasia varioliformis. In literature, it appears to be rare, but it has been classified depending on the different types. It has been classified either acquired HIV-associated, and sometimes it is associated with also malignancies. And in this case, this usually occurs in patients that are immune compromised, and sometimes who have a genetic defect in the EVA gene. However, it has not yet been shown the role of this EVA gene 1 and 2, but in patients with EDV, they have been shown to have a mutation in this gene. So because of the mutation in this gene, these patients are not able to fight off the HPV infections. So most of them, they get now diffuse warts, and in some of them, they end up to evolve to develop into squamous cell carcinomas. So it has been associated with about so many HPV variants, including 3, 10, 8, 13, 20, 12, 14, and so many of the rest. And 10% of the cases have been shown to occur in people who have intermarriages with close relatives, the ones we call the consanguineous marriages. And it has also been shown that genetically, it has been shown to be autosomal recessive, dominant, and some cases of X-linked deficiencies in this EVA gene. So when you see this picture here, these patients, you need to protect them from the sunlight. And then if you see any abnormal skin ulceration, you have to take off a biopsy. If it is a malignant transformation, then you do a wide excision as well as radiotherapy and chemotherapy. Then most importantly, sun protection, and you can give drugs that are keratolytic to try and slough off these different thickened plaques. Then the investigation used in WARTS vary, starting from PCR. If you're in a beta setting, you can do ELISA in situ hybridization and the rest. But we can also take off a sample for histology, and in histology, we usually see this papillomatosis, this elongation of the red ridges, and usually the shape will also be conical, showing the shape of the wart, as you can see, these red ridges curving inward. Then you'll have this hyperkeratosis and also hypergranulosis in some cases. So the treatment options usually vary depending on the type of the wart that you have and where it is located and the desired outcome for the patient. So you may find that as in these treatment methods, we usually divide them to see are they destructive or occlusive therapy. In this case, can have things like cryotherapy, salicylic acid, silver nitrate pencil, cantharidin, surgical ablation, heat, or even laser. So these ones are just destructive methods. Then we can have what you call immunological methods. So you can give things like cementidine, oil zinc, intralesional candida antigens, and then imiquimod. All these are immune modulators that try to wake up your immune system, triggering it to fight the infection. You can also give the antiproliferative therapy. These drugs like they prevent increased turnover of the epidermis. They include bleomycin, 5-fluorouracil, and then acitretin, or even oral isotretinoin in extensive warts. But all these are just trials, and then including the HPV vaccine. They are all trial medicines with different efficacies, and the recurrence is also as high as 30 to 60%. Then you can also give direct antiretroviral therapy. Either you can give it topically, the pseudofovir, or even intralesional. So if someone has a very wart that you cannot excise, you can give intralesional pseudofovir, and then you try to trigger death of the virus such that the body can also eliminate it from the body. So this flowchart tries to explain the treatment approaches when you have a wart and the different options that you can look for. So including things like curettage, things like cryotherapy. So depending on the size of the wart and how the patient has presented, where is the wart and the cosmetic outcome that you are looking at. Then if it is an genital warts, usually it can be medication that you apply you as the practicing dermatologist, or the medication you can give a patient to apply by themselves, depending on the size of the wart. For things like imiquimod, the low concentration, like 5% podophylotoxin, those ones can be patient applied. But if you're doing things like 25% podophylotoxin, that means that you have to apply it as a physician, and that is a procedure that you do in your office. And other things including electrosurgery, excision, curettage, all these things are done by the practicing dermatologist. So the different vaccines that have been availed for vaccination against HPV. We have currently two. We have the Gardasil and then the Cervarix. So the Gardasil usually, for it has different up to 9 genotypes of HPV. But it's a most common vaccine. However, the effectiveness is slightly low compared to Cervarix, which has only two genotypes it protects against, that is 16 and 18. Usually, these are the notorious ones that cause cancer of the cervix. And sometimes someone asks who gets the vaccine. So we can give boys and girls actually aged between 11 and 12 years. So this is before their sexual debut or before them interacting with the opposite sex. This is to make sure that by the time they get to interact, they are already vaccinated to minimize the chances of developing these warts and cancer. So sometimes we also give this vaccine to people aged between 27 to 45 and also be vaccinated. And even in the elderly, we can also give it to minimize the development of these warts. And usually we give 2 doses before the age of 15 or 3 doses if you start at the age of 15 and above. So it gives you about up to 90% protection against cancer and conditions caused by HPV. And side effects are just mild pain at the site of injection, headache, and then a little fevers, and that's it. And we shall look at the few syndromes that are associated with WARTS. The first one being the WIM syndrome. So in the WIM syndrome, we have WIM is just an acronym. So W stands for WARTS, H stands for hypogammaglobulinemia, and then I stands for recurrent infections, and then the M stands for myelocatesis. So in this case, it is a rare primary immunodeficiency disorder, and in this case, someone has immune dysfunction leading to recurrent infections, some of which include warts. So the key features of WIM syndrome include persistent infection with the HPV. Then we have a hypogammaglobulinemia, which will have low levels of antibodies, because if you have low albumin, the gamma albumin, that means that you cannot form most of the antibodies which are formed from that precursor protein. Then someone will get recurrent infections, bacterial, especially sinuses, and then recurrent pneumonias, and then they have also abnormal retention of the white blood cells, that especially the neutrophils in the bone marrow, and that means that you don't have them in circulation, so that's why these infections usually disturb them a lot. This WIM syndrome is due to a mutation in the gene CR4 gene. We know this one is a receptor protein on the immune cells, and it is very, very important in pattern recognition and in binding of the cells and the general function of the white blood cells. So if you are deficient in this gene, that means that you have an impaired immune system. So the diagnosis usually can do blood work. We do a CBC and someone will have a low neutrophil count. They will need to do genetic testing. They have a mutation in the CR4 gene, and this patient will also have recurrent warts. In some cases, they are very extensive, that they cover almost the entire body. And then in treatment, you can have immunoglobulin replacement to boost the function and the formation of antibodies. And then you can give antibiotics to control infections. So you can put them on long-term, maybe PNV, to try and penicillin to try and prevent these staph and strep infections. Then there have been experimental therapies targeting the CXCR4 gene, the Prexafol, which is not yet available in our country, but still experimental. But in this case, at least you can give the antibiotic, and then also if you are in better setting, you can give the globulin replacement therapy. So with treatment, there's usually mild improvement, but this condition stays with the patient for life. So this picture tries to show us the different ones, so we can have like this verrucous plaque on the penis. This is now squamous cell carcinoma, which started as a wart. Now this is a little bit of a giant wart. And now this one is like bovinoid fasciosis. having that change. This is also now cancerous transformation. This is Hex disease, and then this is just this is Wilms syndrome, where someone has extensive warts. So thank you very much. We encourage you to subscribe to this channel and share with your colleagues so that they can get the same information. I'm Dr. Abraham from A&E Dermatology Specialist. God bless you.